Are you curious about Gestalt language processing? You are not alone. Join me, Corinne Smoose, and speech therapy PD for our podcast, The Gestalt Get Together. Our episodes try to balance the enthusiasm and excitement about GLP and its associated intervention ideas, as well as a healthy dose of skepticism about how to understand and integrate this paradigm shift into your career and the field at large. We hope that you can get together with us to learn more about Gestalts.
Welcome to Brainstorms, Functional Neuro Rehab for SLPs, presented by SpeechTherapyPD.com. This podcast is designed for the adult medical speech-language pathologist. Most of our audience members work in settings such as acute care hospitals, private practice, outpatient hospital clinics, and inpatient rehabilitation hospitals. Each episode has an accompanying audio course on SpeechTherapyPD.com and is available for 0.1 ASHA CEUs. The content of this course is based on the research and experience of the presenters. The listener is responsible for researching to determine if the information and skills taught are appropriate for their clients, students, or patients. SpeechTherapyPD.com does not necessarily endorse, recommend, or favor the information shared, nor any of the claims, opinions, statements, offers, or services made by the presenter. Hello, and welcome everyone. My name is Renee Garrett, and I'm your SpeechTherapyPD.com podcast host for Brainstorms, Functional Neuro Rehab for SLPs. Before we get started, we have a few items to alert you to. Each episode is 60 minutes and will be offered for 0.1 ASHA CEUs. Here are the financial and non-financial disclosures. Dr. John Ashford is the owner and educational research director of SA Swallowing Services, PLLC. He receives an honorarium for his podcast participation from SpeechTherapyPD.com, and he has no relevant non-financial relationships to disclose. I am a paid employee of a private consulting firm in the Commonwealth of Virginia. I am the host of Brainstorms, Functional Neuro Rehab for SLPs, and I receive financial reimbursement from SpeechTherapyPD.com. I also receive financial compensation for this and other webinars on SpeechTherapyPD.com. My non-financial disclosure is that I am the current secretary for the Communication Disorders Foundation of Virginia. So joining me tonight is Dr. John R. Ashford, PhD, who again is the Education Director, co-owner of SA Swallowing Services in Nashville, Tennessee. He's retired from the Department of Veterans Affairs as a medical speech-language pathologist and as a professor at Tennessee State University and the Vanderbilt University School of Medicine. Professional interests include understanding factors associated with pneumonia development in patients with dysphagia and educating and training providers of FEES services. We welcome you, Dr. Ashford.
Thank you.
So let's just jump right in because I think this is such a great topic. For me personally, I read through some of the, information that you sent over and just thinking about aspiration, because that's really what we're going to be talking a lot about tonight. And just the experiences I've had with physicians and nursing staff and all wonderful people, but just the amount of miseducation and lack of education really in their programs that teach them about things like aspiration. And so I think, we've been taught as speech language pathologists that it's an abnormal occurrence in people with dysphagia. But, sometimes that's really not true. And I think one of the populations we really have learned that from is particularly with our head and neck cancer patients that are survivors of their chemo and radiation. So what would you say is a standard definition of aspiration?
Well, it's one really basically that Dr. Logeman gave us many years ago. That means that any material that falls through the larynx and falls through the vocal folds, passes through the vocal folds into the trachea, is known as aspiration. Now, more recently, there's been some talk of, we should be considering anything that's laying on top of the larynx that might fall, or on top of vocal folds that might fall. And I don't agree with that because that's I have seen that happen too many times, material on the vocal folds, and you think, it's going to fall in. The person goes, it's gone. And so we should stick with the definition. Anything that passes the plane of the vocal folds into the trachea is aspiration.
I'm with you. I've seen that many times on imaging, whether it was modified barium swallows or fees, where the patient even took a repeat swallow without a cue, just spontaneously did that and everything cleared out. So,
Yeah.
I think again, you mentioned it's important to adhere to that definition for kind of those reasons. Is some people have these adaptive strategies that just sort of happen from their own experience. Some people are very their sensation is intact and they can feel it, and they have their own little things that they are doing without a cue, without us having to tell them, that seem to be working. And another population that I really have uh, struggled to educate physicians and other medical professionals is people with seizure disorders, because a lot of times what happens is they get labeled with this aspiration pneumonia because they vomited during the seizure, which we know is a normal occurrence, and they aspirated the vomit because they're on their back and there's nowhere else for it to go. Gravity, pulls it down, and just the effects of your airway breathing in sucks it back. And it's tough because once those patients get that diagnosis of aspiration pneumonia, it really never leaves them, especially if they're those people who are repeat offenders, as I call them, in the health system, where we see them across multiple admissions, and now they've been labeled with aspiration pneumonia unrelated to a true dysphagia, and they wind up having to see speech every single admission. And again, every case is different, but I think, we see this aspiration event, and then it becomes a whole other thing, a whole other issue.
Well, the aspiration, and you just alluded to it there, was that we can aspirate our oral contents, and we'll talk more about that probably as we go along. But there is this issue of aspirating our gastric contents, whether it's through vomiting or whether it's through reflux, and yes, that can cause pneumonia. There's no doubt about that. But I think really what is more of a concern with those patients is that they get pneumonitis because the hydrochloric acid in the stomach spills over, and then that's a real concern of physicians, that we have pneumonitis versus pneumonia. We can treat pneumonia with antibiotics and things like that, but the pneumonitis is a whole different severity, and so there's a lot of concern there. I think you're right. A lot of people get this aspiration pneumonia title in their records, and it automatically is assumed that they have dysphagia, when no, it was maybe an episodic event, which is a form of aspiration. It's an episodic rather than a continuous event, and there are differences in those.
Yeah, and that takes me kind of to the next question, because again, we think of that as an event we sort of see when we're doing an instrumental exam, whether that is a modified barium or a fiber optic endoscopic procedure, where we're looking at swallowing from kind of the two different realms. And there's definitely deeper levels of aspiration in that more kind of descriptive classification. So what would you say some of those classifications are?
Well, I tell you, if you really break aspiration down, you really have to break aspiration into two components. You have to break it into the event, aspiration, the event. And the other component is the aspirate itself. And those are two different things. And if you're going to be in dysphagia, you really need to have a good understanding of both of those. And so, whenever you're talking about the event itself, for instance, you're talking about the mechanical aspect. You're talking about the biomechanics of it and the inefficiency that's taking place. And that's kind of where I think most of us getting into dysphagia, that's about all we really know about. Oh, okay, well, his muscles are not working like they should. But there's also some other components to that as well. And it's the alertness of the patient that can result in aspiration, the alertness level. There's the aspiration audibility. Do we hear it or is it silent? That's another classification of aphasia. Intake mode. Now, this is a real interesting area. Is it non-prandial? In other words, you're not getting a meal and you're aspirating, or are you a prandial aspirator? And the prandial aspirator is primarily aspiration is primarily what we're looking at when we are doing our instrumental studies. Now, unfortunately for us, that's the only time we witness aspiration is when we do those instrumental studies. Now, people say, well, I witness it, I see him coughing. That's no guarantee. That's not really a witnessed event. And the literature on dysphagia and aspiration really talks a lot about events that are unwitnessed. And so even though we can test these people and see whether or not they're aspirating or not, it may not be a true picture of really what's going on with that individual because they're silently aspirating. The other thing we have to look at is frequency of aspiration. I mentioned a few minutes ago, it can be episodic, or do we have a person who is continually aspirating? And we can talk more about this later. And then, of course, we get into the timing of aspiration. And timing means, well, did the event occur before the swallow or during the swallow? Things that we look at on our instrumental studies. Now, that's one classification or series of classifications just on aspiration itself. But then you get down to the aspirate, and there's some interesting things about that we need to consider. And one of those is source. Where did that aspirate come from? Did it come from the mouth? Did it come from the gut? Just as we talked about. What's in that aspirate? Is it secretions? Is it microorganisms from the mouth, or is it gastric contents, or is it gastric contents that the person's been on PPI and really an alkaline stomach, and next thing you know, you have bacteria coming from the stomach that is causing a pneumonia. So content has a lot to do with it. And then lastly, in trying to characterize or try to give some classification, is the volume of aspiration. Microaspiration versus macroaspiration. And so when you take all of those factors, it's a really complex way of classifying aspiration. What are the different classes? There are a lot of classifications. But if you want to understand aspiration, you need to understand each one of those elements.
Yeah, especially when you have to go and kind of defend your position when you get did they pass or did they fail? Because believe it or not, people still use that. And then you get I'll try to sometimes preface it by saying, well, yes, they had a microaspiration event, but then they were able to cough and clear, and the doctor's like, okay, they got to be NPO, and that's like one of my pet peeves. And then I think going back to what you said about pneumonitis, if you could just, because I don't know what the listeners are, what the level is of understanding of what that means, can you just sort of walk us through what pneumonitis is versus pneumonia?
Sure. Well, if you just take the term itself, pneumonitis. Well, itis means inflammation. Okay.
Right.
And so we have an inflammation now of the tissue of the lower respiratory system. Now, if this gets into, and again, this is maybe a new term for some people, into the parenchyma. The parenchyma is actually the cellular level very outside parts of the lungs, where the oxygen and carbon dioxide transfer takes place, the lung tissue itself. If it gets out into that, it can cause hemorrhages. It can cause a whole lot of damage if it is that caustic. It's burning is what it is. It's hydrochloric acid. And so we get inflammation from it. We have tissue damage from it, like a burn tissue. And so that brings on a whole cascade of problems for this patient in terms of illness. Now, as far as aspiration pneumonia is concerned, or my term for it is bacterial aspiration pneumonia. That's my term for it, because it's different from the pneumonitis, or it may be different from a pneumonia that has occurred as a result of gastric contents being aspirated. The bacterial base means that it's coming from the mouth.
Right.
Bottom line, folks, aspiration pneumonia, its source is the mouth. The mouth is where it is the second largest reservoir of bacteria in the body, second only to the gut. And so it turns over in a big time hurry. So if a person aspirates oral contents that have bacteria, which all of us have bacteria, we all have well over 1 billion bacteria in our mouth as we sit here right now. If we aspirate that, and our immune system is such that it cannot defend against those bacteria, particularly if they become really pathogenic, then it can seep all the way down into the lung parenchyma and cause an infection in the respiratory bronchioles, which inflames the lung tissue itself, and it fills with fluid, and that's pneumonia.
Yeah, no. And again, I don't know who's watching and what the level is of understanding, because I know sometimes we have newer clinicians or maybe even some graduate students. So I thought it was important to define that for that group. Well, and even honestly, some seasoned clinicians I've worked with too.
Well, this area, we've come a long way, and it is a very, very complex. Aspiration alone is, okay, aspiration in and of itself is a consequence. It's a consequence of weak musculature. It's a consequence of dysphagia. So it in and of itself is not really a medical condition. Aspiration itself is a physical phenomenon due to weak musculature that makes our swallow mechanism weaker, and our larynx cannot keep it out. And so we end up having material enter the airway. But I think it's really important for our students and our young clinicians to understand that everybody aspirates. Probably all of you have aspirated in the last few days. Now, you're not going to get pneumonia. That is, if you're healthy. If your body immune system is healthy and normal, then your aspirate that you're getting in there with all that bacteria, you're not going to get sick. The only people who develop pneumonia are people that are sick, and they have a compromised immune system. And this is really important to understand as young clinicians. Just because someone aspirates does not mean that they're going to develop pneumonia. It's not going to happen. In fact, the incidence of pneumonia in and of itself is like 11%. That's very, very low. That's very, very low. And that's worldwide. So it's important to understand just because a person aspirates. Now, the truth is, and I said that we all aspirate, aspiration really is a normal phenomenon. We are supposed to aspirate. We aspirate our secretions every day. They penetrate, and we aspirate small amounts constantly. And we really didn't realize this until probably within the last 10 years or so, of the normalcy of aspiration. And there's a series of papers written by Dixon and his group. What they talked about was, and this was so new, was that they found that we have colonies, communities of bacteria around the carina and the right bronchi of our lungs. It's there permanent. We have permanent bacteria in our lungs. And what happens is, it's like you live in Los Angeles and you move down to Miami. Well, that's what the pathogens, the bacteria, the microbes in our mouth are constantly doing, is moving from our mouth. We're swallowing a lot of it, but some of it's also seeping into our lungs, feeding those little communities that are helping keep the lungs normal. Now, when our mouth goes bad with periodontal disease, those same pathogens then get into the lungs, person's immune system, person gets sick. Well, then those pathogens that are in our mouth and in our lungs now make their way down to the parenchyma of the lungs. And that's when people get pneumonia. And again, I think that's one reason why we have such a low incidence of pneumonia in itself. Now, I'm certainly not downplaying the severity of pneumonia because it causes death. It is serious and it's something we should not take lightly, but I think we have to understand it.
And I think that's a good basis for talking about, and this really isn't what the podcast was going to be about, but the importance of oral care, because I can't tell you the number of times I've gone into ICU for someone who was hospitalized for, pretty long time, maybe on mechanical ventilation for a couple of 3 months. They've been doing the little swab or whatever, and to go in and say, you can brush anyone's teeth. You can brush anyone's teeth, set up suction. They don't even have to be awake for it. As long as you've got the suction ready to go, you can help them not have that crazy colony of bacteria that also occurs with open mouth breathing, which mechanical ventilation. And if you're not trached, you're going to have open mouth breathing. There's no way around it. And probably the worst one that I've ever seen that I got when I was in patient rehab, the worst patient oral care wise who still had dentition and was relatively young was a patient with a TBI who had been on mechanical ventilation for about 6 weeks. And when he came to me and we were able to do a fees after he initially did not do so great on his modified barium swallow in acute care, I put the scope in. I was a brand new clinician. I had just finished my fees training. This was over 12 years ago. I describe it to the students now as stalactites and stalagmites because his thrush was so bad. It went so far past, it was all the way to his esophageal opening. So you can imagine how far it really transcended beyond what we could actually see. And I've never seen anything quite so bad. And every time I show this to students, their gasp is like, oh, what is that? But that's a perfect example of, even if he was just micro aspirating on his own secretions, we're still creating this firestorm for this patient who's already medically compromised, having had a pretty substantial TBI and being in ICU for as long as he was and deconditioning happening. And he's one of the people that got slapped with the aspiration pneumonia diagnosis, which makes sense. But, he did great. He was in IPR with us for quite some time, but he had an emergency room visit a couple of years later. And I know this because I was an outpatient and we got a referral for the same guy for aspiration pneumonia, but he didn't have aspiration pneumonia. He went in because he broke his toe.
Well, because he had aspiration pneumonia once, someone sees it in his chart and says, oh, well, he's had it once. Probability is he's going to have it again. That's it. Getting to this oral care thing, this is one of my kind of pet peeves, and I've worked on it for a number of years. And hopefully I'm going to have a paper coming out on this pretty soon. But oral care is the purview of nurses. Unfortunately, it's left oftentimes to our nursing assistants to do. It is trained in nursing school. Mm-hmm. It is in their textbooks, and they spend a few minutes on it. Everyone thinks that it's, common knowledge. Everyone knows how to brush teeth. Well, let me just tell you, firsthand experience here, brushing someone else's mouth is not easy. It is not, and particularly when you have someone who is a TBI or maybe a dementia patient. These are not easy patients to brush their teeth. And there are methods, there are proven methods of how to do this better. Now, you mentioned the green swab a few minutes ago. Heaven forbid. That is not an oral care product. It is, as they say, it's made to buy and not to use. the green swab, the reason you don't use it to clean the mouth, or at least clean the teeth, is because it has no abrasion to it at all, and so you really need a good brush for that. But it is good for getting the big chunks out and to clean out a lot of thick mucus and stuff like that. It's really that. Yeah, but once you get that cleaned out, then you've got to get to the brush. And one of the really good things nowadays, we do have these electric toothbrushes, and these are easier to manage, and also sometimes easier for our elderly patients to hold on to, and to clean their mouth. So the methods of cleaning. Now back to the nurses again. The CNAs get little training in oral care at all. So I don't like the term oral care, but it's I don't think it should be part of the cares. Bathing and stuff like that. I look at it particularly in acute care and worse, and in some nursing homes even. I look at it, it should be oral infection control, because that's what you're doing when you are cleaning the mouth. You are fighting infection, or because you have infection around the base of your teeth. This is where gingivitis and periodontal disease develop. And if you don't brush your teeth, that plaque just does not come off very, very well. And that's why we all go to the dentist every 3 to 6 months to have that taken off of our teeth as well. Well, if you have someone in the hospital, I was in the hospital recently, a couple of months ago, and I was never offered a toothbrush. I was only there a couple of days, but I was never offered a toothbrush or toothpaste. And so, of course, my wife, knowing me, she brought one immediately. But no, it's not routine, and certainly not routine to have that available for people in nursing care facilities either. So there's a problem, and also one of the big problems with oral care programs is sustainability. How do you keep a program going? Everyone starts out like a house on fire, and we're going to brush everybody's teeth and all of this. But as the day's activities go on for these nurses, they don't have the opportunity, or they don't take the opportunity, or it's not that important that we brush the teeth twice a day. And that's really routinely. This is what the American Dental Association says. Our literature says this. So that's really what we should do. I think, and it's also been proven, 3 times a day for our intensive care people. I've worked with hospitals where they did oral care on their vent patients with every shift change. Mm-hmm. And the incidence of pneumonia just went rock bottom. Because with those shift change every 8 hours, well, you were really in front of this 24-hour turnaround of the mouth. And so they were really holding down, or at least keeping the pockets of bacteria from accumulating. So yeah, it's a tough job, but I think speech pathologists have a role in it. I'm not at all, have not been adverse to the idea of going up to someone and say, "Give me your teeth," and take those false teeth out and let's clean them. Let's clean them up. And it's amazing how they feel with that. Mm-hmm. It's not our primary role,
right,
to do that. But I think we have to be on the team. We have to be the cheerleaders. We have to educate the staff. If we don't want this man to he's coming here pretty sick. If we don't keep his mouth good and clean, then there's a high probability he's going to develop a pneumonia from it. And so we have to be advocates. So it's kind of a difficult situation to be in, but I think we SLPs have a definite role in that, if we understand that the mouth plays a major role in the development of pneumonia in people with dysphagia.
Yeah, I can only imagine if that oral, if you called it oral infection control in a hospital, the way that they look for HAPI and C. diff and pressure wounds and stuff like that, if they kept track of that in the same manner, then your data would be there. It's convincing people and again, keeping them convinced, because those two roles that you mentioned between nursing and particularly with CNAs is a high turnover role. A lot of the
Yes.
CNAs that I've worked with were actually in nursing school, and they were doing this to get a paycheck plus experience. And
Yeah.
so they don't tend to stay for long periods of time.
No.
Some
No.
do, but again, by and large, even with OTs that I've worked with in both acute care and LTACs and IPR, they were more likely to do bowel movement hygiene, and then I call it the nether regions. They're all about that. They don't, no problem. I'm like, you
Yeah.
can't take grandma's dentures out of that nasty cup that came in with her from the nursing home, or the dentures that have been in grandma's mouth since October and it's now March, and you don't
Mm.
want to take those out and clean them. That's just not okay. It's just not. And
Well,
again,
and also if you walk in, a lot of times you can go to the patient's room, the door to their room, and you smell halitosis right off the bat, and you know that no one has cleaned this patient's mouth, and in and of itself, that's terrible. But it's the next level that's even worse, and that is you're not cleaning an infectious situation, and it's also very preventative. I mean, we can prevent prandial or non-prandial pneumonia by simply keeping the mouth clean. The medical literature is just replete with one article after another study showing that if you brush those teeth, boy, the incidence of pneumonia and death drop tremendously.
yeah, and there's even links to other things like with kidneys and their function and all
Oh
that
yeah,
kind of, again, looking at holistically what that does for a patient. But you mentioned a really great point about feeling better. And I know, having had, my dad, when before he passed away, and he had a total of 3 strokes. Um, And then more recently with my mother-in-law, right before she passed away, that was one of the things that I went in and did. Was she said, "No one's brushed my teeth." And I said, "I got you." And it's a care thing. It's a human compassion too. There's a piece of it to that,
yes,
because you mentioned that people feel better. I would be pretty angry. I spent a lot of time in the orthodontist chair when I was a kid,
yeah.
and I would be really mad if my teeth were not getting taken care of.
Well, I have to say, when I was in the hospital, and I've not ever been in the hospital until just recently, and it was great to be able to brush my teeth, and I couldn't help but think back over the work I'd done in the hospital and all this kind of stuff, and these people not getting not even asking to have their teeth brushed, but it meant a lot to me that I had to do it. I really did, and it did
Yeah.
make me feel better. Yeah, in fact, I
And
went home. That was good.
And the other thing, misnomer that people have, is that people who don't have teeth, and if they don't have dentures, they don't need to have any kind of thing going on with. You can gently brush someone's gums and at least get in there, and
Yes, a
again.
soft, or even a baby toothbrush. Now that you brought that up, let's talk about that mouth. Okay.
Mm-hmm.
Um, we know that the hard surfaces of the teeth do attract dental plaque, but those are not the only surfaces in the mouth. We have, and okay, students, here you go. The inside of the mouth is made up of squamous epithelium.
Right.
Now, squamous epithelium are kind of like little pavement stones. They kind of sit on top of each other, and they're several layers thick. And what they do is that they slough off. And this is it prevents bacteria from penetrating tissue. Well, interestingly enough, each one of those squamous cells has a surface area that will hold 100 bacteria. Okay, so it turns out that if you assay our secretions, we find out that the largest carrier of bacteria in our saliva are those cells. Now, that gets back to this thing of, if that's the case, then we should be cleaning those surfaces when we are cleaning the tongue in particular. It holds more bacteria really on the surface than the rest of the mouth does. But that's why we need to ensure that we use that soft toothbrush on people who are edentulous, so that we clean their mouth the same way, because they've got a mouthful of bacteria as well. That's enough to that's
Yeah,
really
and if you've
nerdy.
ever
I understand that's nerdy, but it's a fact. So
no, I was just gonna say, the it's kind of gross, really, when you don't, because when you've worked in particularly acute care, particularly in a trauma hospital, or even the little rural hospital that I wound up in when I decided I didn't want to work in the trauma hospital anymore
yeah,
because it was two of us. It was astounding to see what people's tongues look like when they were extubated, or even just in ICU and maybe hadn't been awake, but were breathing on their own, and they open their mouth the first time and you're like, holy, what in the world is that?
yeah.
So yeah, I think that proves the point, because sometimes the visual is necessary to go with the science backs it up.
Well, and if you're in head and neck cancer and you deal with a lot of these people that have radiation treatments, or maybe some that have total laryngectomies, it's not unusual to find black hairy tongue with those people. And literally when they
Yeah.
stick their tongue out, it looks like a little black forest sitting on top of their tongue. It's gross, but what that is a fungus, and the reason it's there is because they don't have secretions. Secretions have a
Yeah.
lot of immune function. We got to have lots of immune factors in our saliva. And so when you're irradiated, they lose that saliva, and then that doesn't help protect the mouth. Next thing you know, you got these fungi growing in there, and of course, it's also loaded with bacteria as well.
Again, that visual, the
Yeah,
visual to go with
it
the
only takes
science.
once. It only takes once.
Yeah, they should maybe show more pictures of that in the head and neck anatomy class. That would be
Yeah, yeah,
and I had the good fortune. I say good fortune because my clinical instructor for my adult placement when I was a student, it was just an awful skilled nursing facility. And as much as I felt so badly for the patients there, I was really grateful afterwards for the opportunity, because she was fantastic at education and making sure that I was pushed out of my comfort zone to be proactive in speaking up and being an advocate for the patient. So
yeah.
I've always been really thankful for that. And definitely she's one of the people that was like, it's maybe we can't bill for it technically, but it's more of like a human condition, and you need to be practicing with empathy and kindness towards other people. And
Well, and that kind of gets into this situation about us, brushing teeth and everything. We can't bill for that because there's not a code for it. But we can be the advocates, and I've worked with some excellent nurses. I mean, I really have just worked with excellent nurses, and they get on board. And
mhm.
I've seen some very good wards have some good oral hygiene programs. And then I've seen some who just it wasn't important, or at least they never made that connection. And too many other things were important there. So and I hear from a lot of people, and they tell me about those things, and it's this is universal, and it's worldwide. Uh, we see a lot of programs, particularly in Japan, that are really where they use professional people to come in and do oral. Well, we don't have that in this country much. There's some, but not a lot. But in a lot of the foreign countries, France and places like that, they do have professional, dental hygienists, in some cases dentists, who actually come in like once a month, and they really do the real good cleaning and that sort of thing. Well, guess what the result is? Reduced death rate, reduced pulmonary infections. So I mean it's proven. There's even a new kind of profession that's coming out. It's not in this country, but it's really starting in Africa right now, and it's an oral care clinician, and the combining of a dental tech and maybe a nurse, and this person's coming together, and all they're really doing is focusing on the oral health of the patients. and they can clean the mouth, and they know how to do those dental things. At the same time, they have some of this nursing background as well, so they understand that. And so this is kind of a new little thing that's happening. Certainly not here, but it is happening in other parts of the world.
That's really interesting because I think that would probably be, again, just something really helpful because, again, we wind up having people, and this is a whole topic for another day, but we wind up having people who, and I think we saw this particularly, I was in acute care throughout the entire pandemic, and what we saw when people started leaving the field of nursing and therapy as well was that we were grossly understaffed, which were already understaffed to begin with. And then you've compounded all this other stuff that happened due to the pandemic, and then you give someone one more thing to do, they're not going to be super motivated and inclined to do it, even if they
No,
understand the reasons. Because if you're in a step down unit, it's one step down from ICU. You can't take care of 8 patients as a nurse on your shift by yourself. It's just
no.
not okay. There's all these other medical complexities. You've got patients on glucomander and these things that have to be monitored, on a schedule. One of the things they wound up doing at our facility was retrofitting some of the rooms to be vent capable for those COVID patients who were on the vent but were considered stable. And so now you've brought the ICU to the step down unit, and they're
Yeah.
having to do this training they didn't necessarily have, wasn't what they did day in and day out in step down. And so, that's again another topic for a whole nother podcast. But it just speaks to the complexities because we think it's really simple, and it's actually can be a lot more involved to keep and sustain a program going.
Oh, absolutely, absolutely, and that's really the big issue about in nursing homes and also in hospitals is the sustainability of those programs. You've got to have someone who ramrods it and really keeps it going.
Yeah, and the brilliant comment about moving it over to infection control is probably the best idea.
Well, I always look at it this way. If a person has a wound, they do wound care, wound infection control.
Yeah.
and they pay attention to that. They go in and they change that every day, and they really focus on that 2 or 3 times a day to make sure that it's covered right, or that it's got the right ornaments on it, or the lights on it, or however you're going to deal with those wound controls. Well, the mouth is the same way. It's an infectious condition normally. I mean, you literally got bacteria in your mouth that if you just let it slip a little bit, you let it slip 2 or 3 days, you can begin to develop gingivitis, and which can develop into other deeper dental diseases. And next thing you know, this can develop into a lot of different systemic problems, particularly heart problems. And so, I just look at it as it's an infection control.
Hmm.
We know there's an infection there. We know that the bacteria is there. We know it can be caused. All we really have to do is just take 2 minutes to brush the mouth, clean the mouth out,
Yeah.
and use some mouthwashes and things like that.
Yeah, we used to do a 50-50, and I learned this from a dental hygienist who was also a speech language pathologist at my first job. She said, don't ever brush dentures with toothpaste. Use 50-50 mix of mouthwash and water. And guess what they did? They stopped stocking mouthwash at the hospital because of the alcohol content.
Oh, yeah.
So you're like, dang it, we're set up for success until we're not. But thank you for going down that rabbit hole with me.
Yeah. Hey, I
Since,
told you I had to go there.
so let's kind of backtrack a little bit and talk about how difficult just how difficult it has been to identify aspiration pneumonia by physicians because um, again, I think that, going back and you define pneumonitis versus pneumonia, and you did it brilliantly from the science of it all. Because again, I think that getting that label slapped on you is sometimes it's accurate, right? We do have those repeat patients who come back who have chronic disease and chronic illness, and they truly are actively aspirating. And when we see them develop pneumonia, it's because they're having a flare of whatever their disease is, and they're sicker than they normally would be. But again, thinking about physicians and just why it's so difficult for them to identify aspiration pneumonia.
Well, one of the problems internationally is that there's no there has not been a definition for physicians to work from. We gave the definition of what aspiration was, but it's different because there's not a true definition of what is aspiration pneumonia. There are some who even advocate not even using the term aspiration pneumonia because what really is complex for physicians, and you start getting into things like community-based or community aspiration pneumonia, hospital-based pneumonia, nursing home-based pneumonia. Well, really what this boils down to, it boils down to what kind of pathogen caused the pneumonia. Was it streptococcal, staphylococcus, what was it? And so when you can culture and find out what kind of pneumonia it is, then the doctors can treat it. All right. Aspiration pneumonia is not that way. They don't know what causes it. They don't know what pathogens cause it. The other thing that makes it difficult is that aspiration is unwitnessed. It is unobserved. And so it's an event that physicians don't see. They have nothing to go on. Did this person aspirate, or is this something else? Is this some other pulmonary disorder, or was it caused by aspiration? And they don't know that. There's no way for them to know that. In fact, probably most of the aspiration that occurs is unwitnessed. The only time we witness is when we do an instrumental swallow study. And that's the only time you can confirm, and that's under the conditions that they're eating a meal. We can't confirm whether he's aspirating in his sleep or not, or he is in a coma. Is he aspirating? There's a good chance that he is, but there's no proof. And so doctors have a hard time trying to decide what's the source of this pneumonia? And so it's very easy just to simply say, oh, he has aspiration pneumonia. And that may not be it at all.
Yeah, I know I've had patients where it's sort of like, well, what else could it be?
Yeah.
It could be a lot of things.
Well, it could. And unfortunately, what it is, that a lot of times the doctors say, I really wonder what it is. Well, probably the easiest diagnosis is aspiration pneumonia. Mm-hmm. Because we know we all aspirate. We also know that people that are weaker, that are frail, CVA patients, head and neck cancer patients, all of these people, now head and neck cancer patients are a little bit different, but all neurodegenerative patients, mm-hmm. trauma patients, all of these people have motor weakness. They have weakness to their muscles. And so this is usually systemic. It's throughout the body. Well, when you have these conditions, then that really reduces the efficiency of the swallow mechanism. Now, we more often than not, particularly when we go to sleep at night, we get into a sleep paralysis. Even normal people do this, and they aspirate their secretions. So if you've got a sick person, you've got a person who's seriously ill, the thing about them is that their immune system is under attack. And when that immune system cannot keep up with the growth of the bacteria in the mouth and the chest, it can't fight it off, and you end up getting a pneumonia. It's oftentimes pneumonia is called the captain of the ship of death or something like that, because pneumonia from aspiration will take a person's life. Let's say a Parkinson's patient or somebody like that. It'll take their life as a secondary cause. So it's hard to put your finger on, because doctors can't culture it like they can others, like viral and things like that. They can culture those, but you can't culture aspiration pneumonia. And just the fact that it says it's aspiration, that's a physical act. That's not a biological act. And that throws doctors off in making decisions about that.
Well, and goodness sakes, don't ever bring up the 17 things we're supposed to look at when we do a modified barium swallow study. If you've done the MPS IMP or even looked at the protocol for it, because you start talking about all these other pieces of the puzzle that we're looking at throughout the study, and they're like, "Wait, what? well, how did
Well,
you know that? Or how did you know this? And
well, and I'm a big fees person, teach it all the time, and I've done many MBSs. Um, and when we do those studies, we're looking at the biomechanical component of it, which is only one small part of it.
right.
And you've got to. That's only one small piece of the puzzle. You've got to know your patient. You've got to know what's wrong with your patient. You've got to know the health status of your patient. You got to know the status of their immune system at the time that you're seeing them. Then you see that they are aspirating. Then you look in their mouth and you see that their gums are red and all of this. There are a lot of things you need to look at in your dysphagia patients other than looking at, did he have reduced high laryngeal elevation? I mean, that's just one little piece of it. And and really, it goes really so much beyond that. It goes really to the heart of nutrition and hydration. These are the overriding factors in what we should be concentrating on. I'm certainly not diminishing the fees and MBS. I'm not, because I believe in them. In fact, we should be doing them on every patient. And I know people are screaming right now, but if you want to understand dysphagia, you can't look at a person's neck from the outside. You just can't do it. You have to be able to look at it instrumentally to understand the complexity of the biomechanics. But then beyond that, as I said earlier, there are things like content of the aspirate, when are they aspirating, how much are they aspirating, what does their mouth look like, what's their immune system like. I'm sorry, I can go on and on here, but
No, go on and on.
so complex to understand your patient.
Yeah.
You've
Well, and I
got
think
to
too,
understand the patient.
when we're looking at fees in particular, um, it's really important to not only for you to look at the patient holistically, but again, you have to look at I completely my train left the station, and I think it might be left permanently. I was going to say something really smart and brilliant, and I think the time change might have just like smacked me right upside the head. But yeah, no, I'm trying to remember now what I was going to say.
Well, one of the things that we've done with fees, my team here at SAS, we've really worked on the biomechanical aspects of that. We approach it differently than MBS. Of course, we incorporate a lot of what we learned on MBS, but really trying to make sense of the biomechanics and the possible biosensory components to it. But we are really, as a company and as a group, what we've tried to really do is move beyond aspiration. Truly, those studies are not. People say, "Well, we're going to do a fees, or we're going to do an MBS to see if he aspirates." No, you're not. You're doing a fees and MBS to see how well he can take nutrition and hydration. That's
Right.
what you're doing those for. And aspiration is just such a small part, and penetration is even less. People get
Yeah.
all about penetration. Hey, we all penetrate. Every normal person penetrates. You do it every day, just like you aspirate every day.
Yeah.
And we can't change people's lives by simplistic ideas about dysphagia.
Yeah. Pass or fail.
Yeah. And when you take a person off of food because they dribble a little bit of aspiration, they trace aspiration. Oh, he aspirated, we can take him off and put him on a diet. Now you've done him worse than he would if you'd have left him on it. There's no proof that aspiration of liquid causes pneumonia. Okay.
I know what the thing was I was going to say, and this is again really for everybody, because I don't know that everyone is trained the same way that I was trained when it came to fees. But one of the big components of what I was taught and what I had to be a witness to, whether it was through observation or through when I was actually passing the scope, was normals. We needed to know what normal looked like in a variety, again, of those physiological aspects, because everyone's body's a little bit different. even if they don't have a neurological disease like a stroke or a TBI. There's a wide variance of what we see. And the same thing with modified barium swallows. You need to be able to identify on your instrumental exams what is normal, because sometimes normal in textbook fashion may not be this strict adherence to a set of rules. It's the anatomy variation. It's that person's physiological difference that makes that normal for them, but maybe not for Joe who had a massive stroke.
That is true. That is true. There's no truly, I mean, you got the textbook, it looks real clean. You go to conferences and they show you their best videos. In real life, that's not the way it is. It's very, very complicated. And you've got to know what you're looking at. Let me just make one more little statement here. One thing that we've been doing, keeping data on, is how well SLPs know their anatomy. Let me just say it's horrible. Okay. Yeah. We give a little test at our fees course, and we give 23 tokens, 23 anatomy things they have to label. The average score out of about 300 people now is 5. We have to learn how to identify the structures of the throat if you're going to be a degluttologist. You got to know that anatomy, and you got to know its physiology. Truly, the average.
No, I want to go across the hall to my office and get my larynx out that I use as a teaching tool. Because what I find with patients a lot of times is, particularly when in outpatient, is they don't necessarily buy into what you're telling them because they don't have familiarity with this level of anatomy that we're trained in and should know. But to have that model there that you can pull apart and say, this is what your vocal cords look like, because we have to, I break it down so that they can follow along. This is your arytenoid cartilage. This is what this is supposed to do when you swallow. If you have this is what this isn't doing, in order for you to, again, go through it from the top to the bottom. And then, adding in the esophagus is, again, that's a whole other hour of talking. So there's a lot to break down. And in order for your patients to have buy-in, particularly for outpatient programs, for a home exercise program where they're able to go home and do some dysphagia exercises, they're not going to do it if you just go, yeah, you aspirated that one time on that swallow study with that girl who's only met you that one time, or that guy who's only met you that one time for your 20, 30-minute swallow study, if that.
Well, you just touched on something that I think is really important for your audience, particularly the young clinicians, is that when you're doing an instrumental study, if a person aspirates, you don't stop your study. I don't care how bad the aspiration event is. You don't stop your study. Your study, even though your radiologist may be screaming at you, you have just started your study. And let me also say, every one of you adopt a protocol. You use it every time you do a study. You do the whole protocol on every patient every time. I could talk for an hour on that, but I won't do that anymore. But anyway, that's a point really to be made, is that just because someone aspirates is not a reason to stop a study. And aspiration, by the way, aspiration is not abnormal. Okay, we all do it. It's a common occurrence. But I think in aspiration, we really have to be concerned about, and probably our instrumental studies are best for this, is to looking at the person who macro aspirates. They aspirate large amounts. We should be more concerned not about pneumonia with those patients, but we should be more concerned about choking risk.
Mm-hmm. And that is the only time I've ever stopped a modified barium swallow, was when we did have someone that happened to, and we had to call a medical response team. And again, that's not a fun day, but it's in the 10 years and 8 months that I was 10 years in acute care. I think that was one time, and I probably did, 500 to, I don't even know how many I did in a year. I don't know. It's a lot. I mean, you do them every day, and you do multiples a day. And so you don't, you don't really check that box anymore. You just know it's a lot, and you've seen a lot. And that was once in that time frame across a good variety of ages and across a good variety of diagnosis. So I'm with you. Don't stop. And again, advocate, because the radiologist isn't going to want to hear it, but you're going to have to come in armed with literature. They love that. Or they hate it, but they hate it really because they don't want something else to do, but they will more likely to listen and follow along with you when you're able to back it up with research.
Yeah, and when you finally get across to them how complex this process is, it is the most complex motor action in the human body. I mean, that's what we bought into.
How important is it in the prevention of pneumonia from aspiration, to wrap it all up?
Well, it is very important that you understand what aspiration is and what aspirate is. You need to understand that. The incidence of pneumonia is in and of itself very small, but it is a very complex process that it's not aspiration in and of itself is just the vehicle. The cause is in the mouth and the cause is in the immune system. And that's what you need to be aware of. I call them the 3 pillars of aspiration pneumonia.
I think I've read that somewhere with your name on
really?
it.
Oh, really? Yeah.
Maybe.
Oh, well, I know we're at the end here, but how that got started was I didn't understand why people got pneumonia after having a stroke. I said, how can you get a lung infection and just have a blood vessel blow in your brain? I don't understand that. And I asked for years and years and years and years, and I asked pulmonologists, I asked everybody, and I couldn't get an answer. I couldn't get an answer of these people. And so it really became a career-long and continues to this day, a study of what causes these things. And that's finally, I found reading some other people's work and things like that, putting those three things together. And I gave it that visual image of what are the 3 things that support pneumonia development. Those 3 things: unhealthy person, aspiration, and a bad mouth.
Well, and I think that is a perfect way to wrap it all up. Thank you so much, Dr. Ashford, for joining us. I really
thank you for
appreciate
inviting
you.
me. I enjoyed it.
For sure. I really appreciate you coming on.
Yes.
Of course, that was a great way to wrap it up with the 3 pillars of pneumonia, because that's one of the things, again, I go back to with physicians, because they hear that and then they're like, the wheels start turning. So anytime we can take something like that and use it not only as advocacy, but education for our peers is very important. So thank you for that.
Yes, ma'am.
Thank you again for joining us, and I look forward to seeing you again.
If you have indicated that you are part of the ASHA registry and entered both your ASHA number and a complete address in your account profile prior to the course completion, we will submit earned CEUs to ASHA. Please allow 1 to 2 months from the completion date for your CEUs to be reflected on your ASHA transcript. Thank you for joining us at today's podcast. Remember to go to speechtherapypd.com to learn more about earning ASHA CEUs. We appreciate your positive reviews and support and would love for you to write a quick review and subscribe.